Hello friends, Dr. Nair Zakazmi again with a fresh episode, and today I'm going to explain renal tubular disorders for pediatric practice. Now this is considered to be a tricky and usually difficult area for many pediatric residents and doctors. So I'm going to try to keep it as simple as possible, and we'll try to incorporate some examples for better understandings of the concepts. So let's go. Um, So let's begin with classifying these disorders. Now, kidney problems in pediatrics can be very broadly and functionally classified as glomerular disorders and tubular disorders. Now, glomerular disorders are relatively easier to diagnose based on their discrete clinical features. Like if you've got glomerulonephritis, so they usually present with discolored urine, cola-colored urine, or hematuria. They usually have got some form of generalized swelling as well. They are hypertensive, and they can have a predisposing history, like a history of sore throat or other associated disorders like SLE, etc., etc. So they are relatively easier to diagnose. Now, in comparison, tubular disorders are a bit difficult to diagnose because of the varied and very non-specific presentations. So the common features by which the tubular disorders present, they are so non-specific that they can be presenting present in a wide variety of disorders. So relatively they are a bit difficult to diagnose. Now we start with a clinical case scenario. Okay, so before I start delving deep into this ocean of pediatric nephrology, let's start with this clinical case. So an 11-month-old infant is presents to the children's emergency department because he's got a history of fever for the last 2 days, and that is associated with vomiting. The mom says he has been drinking a lot during this illness, and he's been sweating his nappies as well. Now you do a physical examination, which is unremarkable. You can't find any focus of infection. You give him paracetamol, and within an hour, the temperature settles down. Rather, it goes a bit low, and the child temperature is now 35.9 degrees Celsius. He feels a bit cool. So, still, because you are not clear about the focus of infection, so you decide to do some preliminary investigation. You start with a cap gas, and you give a pot to the mom to collect a urine specimen. So you do a urine tip as well. So the results are here on the right side. So you see the pH is 7.25. Okay. The PO2 and PCO2 seems to be normal. Lactate is 1.1. Bicarb is 19.8. Glucose is 3. Sodium is 138. Potassium 4.1. And calcium 1.7 millimoles. The urine depth shows a specific gravity of 1.025. Ketones are nil. The urine depth is showing is glucose of +2, proteins of +1, no blood, no nitrites, and leukocyte esterase is also nil. So if you're watching my video, you can stop the video here, take a break, try to think over this case. You can write your differential based on your clinical reasoning, and then you can start from the same point. I will come to this case later in my video. Okay, so let's move forward. And as far as renal tubulopathies are concerned, they are basically disorders of renal tubules in which they have defects of enzymes or defects of absorption, which primarily results in loss of anions, cations, different minerals, and they cause a disturbance in acid-base balance and the relative deficiency of substrate because of defects in reabsorption. It causes a wide constellation of signs and symptoms, which I will explain later. As I said earlier, they are relatively difficult to diagnose, and most of the times they are picked up when you are doing a workup for some other presentations. Okay, and most of the time they present with either metabolic acidosis or alkalosis. Now this is a diagram of nephron, okay, and the different components of the nephron. Now here you can see the blood coming in through the efferent components of small renal arterioles, which passes through a tuft of capillaries, which is known as glomerulus, and which is further enclosed in a cup-like structure called Bowman's capsule. The blood is filtered here with many anions, cations, amino acids, glucose, uh, bicarbonate being filtered here, and it goes down the tubule. Now much of it is reabsorbed back into the proximal convoluted tubule, and the rest is gradually absorbed back along the journey down into the descending and ascending loops of Henle, then through the distal convoluted tubule and the collecting duct system, and ultimately the rest of the stuff goes down the renal calyces, then down into the ureter, then down into the bladder, from where it is eventually pushed out of the body. So in the next diagram, I will explain this in a bit more detail. But if you just here, this is the tuft of the capillaries, which is known as a glomerulus. So the blood coming here is filtered out into the Bowman's capsule, and from here all the solutes, they go down. Now this is the proximal convoluted tubule. Majority of the cation anions are reabsorbed here. Then the rest of the stuff goes into the descending loop, then the ascending loop of Henle. Some of it is absorbed back over here. Then this is the distal convoluted tubule, and then into the collecting duct. So all these parts of the tubules, they've got a function, and most of that function is associated with reabsorption of the solutes and water. And if there's any defect, then we get what we call as these renal tubulopathies. So I will explain this in the next diagram. And here you can see how different solutes are reabsorbed back into the body at different levels of the renal tubule. So here you can see this is the Bowman's capsule, and this is the proximal convoluted tubule. And if you come down here, this is the descending loop of Henle. Then we have got the ascending loop of Henle. Now this is the distal convoluted tubule, this part, and this is the collecting duct. So here you can see most of the organic compounds, including glucose, ions, water, and amino acids, they are reabsorbed back into the body from this part of the renal tubule, which is known as the proximal renal tubule. As the rest of the stuff goes down into the descending loop of Henle, you see the osmolality gradually increases. Now here in the descending loop of Henle, water is reabsorbed back into the body, while in the ascending loop of Henle, most of the sodium and chloride is reabsorbed back. As we reach the distal convoluted tubule, the water, calcium, sodium, and chloride, which is left from here, is also reabsorbed back. And finally, the ultrafiltrate goes down into the collecting tubule, where the osmolality is quite high, and then eventually it goes down through the collecting ducts into the renal calyces, and then through the ureter down into the renal bladder. So going on to the next slide, we see that, as I said earlier, that the features of renal tubulopathies are very, very non-specific, and they can occur in a wide variety of diseases. Now, usually the diagnosis is made when you are doing a workup for some secondary presentation of an associated problem like infection in these cases. And the clinical features are, number one, usually majority of them would present with growth failure, and this growth failure starts in the first year of life. They may either present with weak bones, which you call as bone demineralization, so that might be evident in the form of pathological fractures, or they might present with features of vitamin D deficiency. Many of them have got polyuria and polydipsia because of the problem in the reabsorption. So a lot of water is lost, and at the same time, because of the thirst, they are drinking too much. They can have dehydration because of the loss of water. They are usually anorexic because of the imbalance and either having an acidosis or alkalosis. They can have vomiting because of the electrolyte disturbances. Sometimes they can present with constipation, and many times they can present with hypotonia secondary to hypokalemia and hypocalcemia. So as you see, these signs and symptoms, they are quite non-specific, and you can get that in many types of diseases. So that's why it is very difficult to diagnose. It's usually, as I said, like if somebody is presenting with an infection and you are doing a workup, you might see something on the blood gas, which is pointing towards a renal pathology, and then further workup might show you that they have got an underlying renal tubular disorder. Moving ahead, this is the different types of renal tubular acidosis. So renal tubular acidosis are renal tubular disorders which primarily present with metabolic acidosis. So They are of three types. Type 2, which is the proximal renal tubular acidosis, the type 1, which is the distal renal tubular acidosis, and the type 4 renal tubular acidosis, which occurs due to problem in the collecting duct. Now, again, if you see, this is the Bowman capsule and this is the proximal convoluted tubule. Now, problems here with reabsorption, we call them as type 2 renal tubular acidosis. Now, ideally, some people think that this should be type 1, but this is how the system is classified. Type 2 comes before type 1 if you go in a logical sequence along the length of the renal tubule. So type 2 is proximal renal tubular acidosis, and because most of the anions, cations are reabsorbed in the proximal renal tubule, the thing is that if there is a problem here, it would lead to impaired bicarbonate reabsorption, and when bicarbonate cannot be reabsorbed back into the body, so there is relative deficiency of bicarbonate, and that leads to metabolic acidosis, so the blood pH would go down. Now, initially, because there is a loss of bicarbonate in the urine, so the pH would initially be alkaline, but because the distal part of the renal tubule is working, this part is working, so what happened, it compensates by, the bicarbonate which is lost here is reabsorbed back over here. So initially, even if the pH is high, later on the pH goes down into the acidic range. So usually you'll see that the pH initially, though high, in the later stages of disease, it's still less than 5.5, and it's always associated with the hypokalemia because there is a problem with the reabsorption of potassium. So in type 2 renal tubular acidosis, which is known as a proximal renal tubular acidosis, the problem is primarily the problem is in with bicarbonate reabsorption in the proximal convoluted tubule. The second one is the distal renal tubular acidosis, which is also known as type 1 RTA. Here the problem is with impaired hydrogen ion secretion. So what happens normally over here, the hydrogen ions would be secreted into the tubular lumen. So if there is problem with the hydrogen ion secretion back into the tubules, what would happen? The hydrogen ions would be retained by the body. That would lead to a decrease in pH, and that would lead to acidosis. So again, this would lead to a metabolic acidosis in the body, and in this case the urine pH is always greater than 5.5, so you always get an alkaline pH in type 1 distal renal tubular acidosis. And because of the alkaline pH, and because there is problem with calcium reabsorption as well, what happens is that there are chances for calcium over here to get precipitated and form renal stones. So type 1 distal renal tubular acidosis usually presents with nephrolithiasis because a lot of calcium is being filtered. That calcium coupled with alkaline urine leads to stone formation, and they can present with with renal stones, which can lead to repeated infections, that can lead to abdominal pain, that can lead to vomiting, and that can lead to other associated problems like hematuria, etc. as well. Hypokalemia is also a feature of type 1 distal renal tubular acidosis. And then the third variety is the type 4 renal tubular acidosis. Now, this occurs because of the defects in the collecting duct. And what happens basically is that in this particular type of renal tubular acidosis, there is a problem with aldosterone receptors. So when the aldosterone comes, it cannot act on its receptors because the receptors are faulty, and because of that, what happens is that there is hyperkalemia because the exchange of potassium with the sodium, that cannot happen. So what would happen is that the potassium is excreted out and sodium goes over here. So when this is blocked, because the aldosterone is not able to exert its effect on its receptors, so what would happen? Potassium cannot go into the renal tubules, and consequently sodium cannot come in. So what would happen? There would be a relative increase of potassium in the body, and that leads to hyperkalemia. So while there is hypokalemia in type 2 and type 1 renal tubular acidosis, there is always hyperkalemia. So K would be increased in type 4 renal tubular disorder. Um, Now, this is the logical sequence of the nephron. You can see it over here. So this is the Bowman capsule. This is the proximal tubule, okay? And the defect here is we call it type 2 renal tubular acidosis. In the distal tubule, the defect is known as the type 1 renal tubular acidosis, and this is the type 4. Now, an important way to remember this, if you logically see, it's 2, then 1, then 4. So 2, 1, 4. And if you then look at the potassium, here the potassium is low, here the potassium is low, and here the potassium is high, as we discussed earlier. So if I make a table over here, this is type 2 renal tubular acidosis, type 1 and type 4, based on the logical sequence of how the nephron is organized in the kidney. So 2, 1, 4, low, low, more. So this is a way of remembering this. 2, 1, 4 and low, low, more. For potassium, low, low, more. So type 2 and type 1 would have low potassium, and type 4 has got more potassium in the blood. So 2, 1, 4, low, low, more. So type 2 and type 1 would have low potassium, while type 4 would have more potassium in the blood. Now, as far as calcium is concerned, as I said, that only type 1 is associated with high calcium in the urine, because high calcium is filled, and that leads to nephrolithiasis. So more chances of kidney stone formation in type 1 or distal tubule renal tubular acidosis. So that's how you can differentiate. And the other differentiating feature is urinary pH. So urinary pH would always be more than 5.5 in type 1, while it would be acidic in case of type 2 and type 1. So remember, 2, 1, 4, low, low, more. If there are kidney stones in renal tubular acidosis, there's only one condition, which is known as type 1 renal tubular acidosis, that causes renal stones. And the pH in type 2 and type 4 is acidic, while in type 1 it is alkaline, which causes more chances of precipitation of calcium and hence renal stones. And now moving on to renal tubular disorders, which present with alkalosis. Now, before this, we discussed actually renal tubular acidosis, which presented with acidosis, that were like type 2, type 1, and type 4. Now, there are three syndromes which cause tubular alkalosis, basically renal tubular alkalosis, and they are Barter syndrome, Little syndrome, and Gitelman syndrome. Now, there is another syndrome which is known as Fanconi syndrome, but Fanconi syndrome basically present with metabolic acidosis, and one of the common causes of type 2 renal tubular acidosis is Fanconi syndrome. Now if you find alkalosis, metabolic alkalosis on cap gas, then there are three disorders which can present with that: Barter syndrome, Little syndrome, and Gitelman syndrome. Now, how do we differentiate between them? So let's move on to the next slide. So here you can see the difference between Barter and Gitelman, and I will just write Little syndrome over here. So Barter syndrome is autosomal recessive. Gitelman is also autosomal recessive, while Little syndrome is autosomal dominant. So usually more common in consanguineous marriages, these two, while this one is autosomal dominant. Now, the problem with Barter syndrome is that there is a genetic defect in the thick ascending loop of Henle, okay, and that defect is in the sodium potassium chloride co-transporter. So basically the problem is in this channel, that is the sodium, potassium, and chloride co-transporter. Okay, so what happens is that when this co-transporter is not functioning properly, so what happens, there is a lack of concentrating ability of the renal tubules. So what happens is that you are losing potassium in the urine, you are losing chloride in the urine, okay, and so there is usually hyponatremia, hypokalemia, as well as hypochloremia, and we call it as chloride resistant metabolic acidosis, because even if you give them chloride, the chloride level doesn't go back to the normal because it's being constantly lost in the urine. Now, it usually presents early in life. Barter syndrome and polyuria and polydipsia are quite common. So these babies, they drink a lot, okay, and they are constantly wetting themselves. Now, another important thing is because there is increased urinary calcium excretion in Barter syndrome as well, and this is just very much similar to the distal renal tubular acidosis. So the only difference there, you had acidosis, here you've got alkalosis. So increase flow of urinary calcium predisposes them to stone formation, and these kids who can also present with renal stones, with nephrolithiasis. So they can present with repeated urinary tract infections. You do imaging and you might find them that they have got stones in either one or both of the kidneys. One important thing is that in Barter syndrome, the renal prostaglandin E2 secretion production is enhanced, and despite that the renin activity is increased, the blood pressure is still normal. So this is quite peculiar to Barter syndrome, that despite having high renin activity, you will still be the child would still be normotensive. You would get basically hypokalemic, hypochloremic metabolic alkalosis with the normotension in Barter syndrome, and they have got a predisposition to develop kidney stones. Now, some of these kids usually present with sensory neural deafness as well. They might have peculiar triangular faces, large eyes, and can develop renal failure as well. Now, in contrast, the Gitelman syndrome, the problem is in the distal convoluted tubule, and the defect is in the sodium chloride co-transporter. So this is the defect. So there is a defect in the channel sodium chloride co-transporter, while the defect in Barter syndrome was in the sodium potassium chloride co-transporter. So there is difference. This is sodium plus potassium plus chloride co-transporter, while in the distal convoluted tubule you've got the sodium chloride co-transporter. So what happens is that the sodium and chloride, okay, they cannot be reabsorbed back, and what happens is that the child has got hyponatremia, hypochloremia, and hypokalemia as well. Now, this usually presents more in late childhood. There is again no hypertension. Polyuria and polydipsia can be the presenting features in these kids. They can also have neuromuscular symptoms like muscle cramping and spasms because of the hypomagnesemia, which is one of the cardinal features of Gitelman syndrome. In Gitelman syndrome also, you do not get any hypertension. Kids usually have got normotension, or sometimes they can develop hypotension, but not hypertension. Now, coming to Little syndrome, which is an autosomal disorder, and it occurs because of the defects in epithelial sodium channel. So the problem is in the epithelial sodium channels in the collecting duct. So these epithelial sodium channels, okay, they are responsible for reabsorbing sodium back into the body. So sodium would go back into the body in exchange for potassium. So when the sodium can't go back into the body and the potassium can't go out in the tubule, so you have got relative increase in potassium. Okay. Oh, I'm sorry. I went the other way around actually. Sorry. So let me once again explain this thing. So these epithelial sodium channels are responsible for reabsorption of the potassium in turn in return for sodium. So sodium goes out into the urine, and the potassium has to be taken back. So when this epithelial sodium channel is not working, so what would happen? Sodium cannot go out out of the body in exchange for potassium. So sodium would be reserved in the body and potassium would be lost. So you would get hypokalemia and hypernatremia. Again, hypokalemia because the potassium cannot be reabsorbed back, and hypernatremia because the sodium cannot be filtered out in the urine. And this is because of the problem with epithelial sodium channels in the collecting duct. So what you get is, because of the hypernatremia caused by sodium not being filtered into the urine, this is the only renal tubular alkalosis which presents with hypertension, and the hypertension is because of the retained sodium. So if you get metabolic alkalosis with hypertension, think of Liddle syndrome. Now moving on to the clinical case scenario. Okay, so I told you earlier that an 11-month-old infant presented to the children's emergency department, and he presented because of fever for the last 2 days associated with vomiting. Now mom said he had been drinking a lot of water, and he's been wetting his nappies. Physical examination was unremarkable. You couldn't find anything on your examination. The temperature was slightly raised. Let's say it was 39, and by giving paracetamol it came down, and now it is 35.9. Rather, he's slightly in the hypothermic range. His peripheries feel a bit cool. So you were not clear about the diagnosis. You started with the cap gas and you did a urine dip, and these are the results. So we start with the cap gas. So here you can see that it is showing a pH of 7.25. So this is acidosis. Okay, and if you see, the PCO2 is normal, but the bicarbonate is low. Okay, so this is metabolic acidosis. So here you find a metabolic acidosis. Okay, now the lactate is fine. Okay, 1.1. Okay, normally with the infections, or when the child is quite dehydrated, or when the child has got poor perfusion, or when there are chances of sepsis, the lactate would be usually high. But what you see here is that the electrolytes are fine, but glucose is low. Okay, and you can understand because the child has been vomiting, so sometimes the glucose can be low. Now you do urine dip, and the urine dip is showing you nil nitrites, nil leukocyte, nil blood. Okay, so probably you have ruled out UTI on this basis. But what is showing? It's showing 2+ of glucose. Okay, and 1+ of protein. Now normally glucose you should only find in urine if the glucose is crossing the renal threshold. It means if there is hyperglycemia, okay, like happens in diabetes, then the urine should filter out glucose. But here you are actually seeing that the glucose level is almost normal or low normal, and with that still the urine is filtering glucose. So what does that mean? It means that there is some problem at the tubular level. Okay, so there is problem with the reabsorption of the glucose, and the glucose is being filtered out despite normal glucose levels. Okay, so we think that this is probably a tubular pathology. And when we think of glucose, where the glucose is reabsorbed, it is reabsorbed in the proximal convoluted tubule. Okay, so there is some problem in the proximal convoluted tubule. Okay, so if you see, if there is a metabolic acidosis with some problem in proximal convoluted tubule, okay, what do you think of that? Yes, you're right. This is proximal RTA, proximal renal tubular acidosis, and one of the common causes of proximal renal tubular acidosis is Fanconi syndrome. Okay, so in Fanconi syndrome, it's not only the glucose, there will be leakage of amino acids, phosphates, calcium. Okay, so many things in the urine, and the child would be having, failure to thrive. He would be having hypotonia. He would be having polydipsia. He would be having polyuria, and he would be more prone to infections, repeated infection, etc., etc. So in this case also, the child underlying problem was diagnosed because he presented with some form of infection, and as you tried to find out the cause of infection, you came across interesting findings which are pointing towards an underlying condition, which in this case is proximal renal tubular acidosis, most probably Fanconi syndrome. Now moving on, I'll give you some clinical cases for practice. Okay, and these are based on, let's say, the blood gas and urine dip findings. Okay, so the first case is an 18 months old with tibial fracture. Okay, so somehow this child has got a toddler's fracture. You did an x-ray, and x-ray is not only showing the fracture, but it's also showing decreased bone demineralization. Okay, You try to find out what's the reason for this decreased bone mineralization, whether the child has got rickets or any underlying problems. You do a blood gas, and this is showing a pH of 7.22, bicarbonate 15, sodium and potassium 135, and 2.5, chloride 116. Urine pH is acidic, and blood pressure is normal. So you see the pH is low, the bicarbonate is low, okay, sodium is, I would say, slightly low, potassium is more low, chloride is increased, okay. So hyperchloremic, hypokalemic, metabolic acidosis, okay, and this goes in favor of what? Yes, this is proximal convoluted tubule based problem, and this is renal tubular acidosis type 2, proximal renal tubular acidosis, okay. Now, case number 2, a 4-year-old thin boy. He's got severe recurrent abdominal pain and he's got failure to thrive. pH is 7.25 with a bicarbonate of 18. So this child also has got metabolic acidosis, okay. Sodium is low, potassium is low, chloride is high, but look at the urine pH. Urine pH is alkaline, okay, and I told you that if a child has got metabolic acidosis, but the urine is alkaline, okay, then you think of what? Yes, type 1 renal tubular acidosis, okay, which is a problem in the distal convoluted tubule. And this child is having recurrent abdominal pain because of what? Because of kidney stones. 5-year-old with partial deafness and recurrent abdominal pain. He wears diapers at night. pH is 7.49. Bicarbonate is raised. pH is raised. Okay. Sodium is low. Potassium is low. Chloride is also low. Okay. And urine pH is quite high. Okay. Or it's in the alkaline range. Okay. So this is metabolic alkalosis. Metabolic alkalosis with hyponatremia, hypokalemia, and hypochloremia. Okay, so this is Barter syndrome. Okay, Barter syndrome. Okay, and the child has got abdominal pain again because this, just like the type 1 renal tubular acidosis, in Barter syndrome you also get recurrent abdominal pain because of high chances of nephrolithiasis, okay, or nephrocalcinosis because of renal stone. And he wear diapers at night because probably he's got nocturia, okay, and leaks his urine, okay. A 4-year-old with generalized chronic fatigue and weakness. His pH is 7.5. The bicarbonate is high, okay. pH is also high. Sodium is high, okay. Here you see the sodium is high. Potassium is low, okay. The chloride is also low. Urinary pH is alkaline, and the blood pressure is a bit high because of this increased sodium, okay. But here what you see is metabolic alkalosis. So metabolic alkalosis with hypertension and hypernatremia, yes, you are very right, this is Liddle syndrome, okay. And then finally you've got a 7 weeks old with recurrent vomiting and failure to thrive. Here also you get a metabolic alkalosis, okay, hypokalemic, hypochloremic, and the blood pressure is either normal or low for age, and he's 7 years old with recurrent vomiting, his failure to thrive. What do you think of it? Okay, yes, this is not any renal pathology. This is congenital hypertrophic pyloric stenosis. So this is pyloric stenosis, okay, in which there's an olive shift masked in the pyloric antrum, okay, that leads to gastric outlet obstruction. And the kids who have usually around 4 to 5, 6 weeks of age, they start having recurrent projectile vomiting. They've got failure to thrive, and they present with these types of findings. So gave you some exercises to practice and try to reach diagnosis with the CAP-GAS results and with the urine dip results. I hope you have enjoyed this lecture. You have gained something from that, though this is not I have not discussed all of renal tubulopathies. It's just some of the common things, okay, which are important for pediatric practice. So if you have liked it, just subscribe to my channel, okay? And you can comment if you've got any difficulty, or if you've got any question, please do ask me. Thank you very much. Bye.